Hi everybody, and thank you for joining me in this new video presentation regarding ECG exercise number 22. I hope you will enjoy it and join me here in my future video presentations. If you are new to my channel, please do not forget to subscribe. Now let's go together to the ECG of the week. So our patient is a 53-year-old man with frequent history of palpitation, with no syncope or presyncope. The patient went to another center in the emergency department. They documented a wide QRS complex tachycardia. The tachycardia was terminated reportedly with verapamil. They make the diagnosis of verapamil sensitive VT, idiopathic VT, and then they refer the patient to our center for catheter ablation. Now let's look together at the ECG of the patient in sinus rhythm. As you can see here, we have T-wave inversion in inferior leads and also in the lateral leads. Of course, this might be the memory effect. However, this may alert us that there might be some underlying structural heart disease, although at that center echocardiography and coronary angiography were normal. The patient had normal LV size and function. Let's have a look at the ECG. Like every ECG with wide QRS complex tachycardia, the first question is VT or SVT with aberrant conduction? We have many criteria in this ECG which suggests ventricular tachycardia as the underlying arrhythmia. For example, we have a QRS duration more than 180 milliseconds. We have a monophasic R wave in the lead V1, and at the same time we have the QS pattern in lead V5 and V6, both suggesting ventricular tachycardia. In addition, the AVR shows a monophasic wide R wave, and this also suggests ventricular tachycardia. In the inferior leads, from the beginning of the QRS to the deep of the Q wave or to the peak of the R wave, it's more than 50 milliseconds, and the same interval in precordial leads are more than 100 milliseconds. So all these criteria suggest ventricular tachycardia as the underlying arrhythmia in these patients. Now let's look together at the MRI of the patient, and this is very interesting. On the right side we see the MRI, which shows a large epicardial scar in some area extending to the endocardial side, which suggests a scar formation after previous myocarditis despite preserved LV function. On the left side we see the CartoMap's bipolar and unipolar voltage map showing the same scar area on the same location, and as you can see here on the epicardial side we have the late potentials. On the endocardial side we had the best pace map, and after ablation on the epicardial side we rendered the VT non-inducible. So in conclusion, this is an interesting patient with hemodynamically stable ventricular tachycardia in echocardiography and coronary angiography. There was no clue to structural heart disease. However, MRI make the correct diagnosis, and this once again emphasizes the important role of imaging, especially the MRI, in evaluation of patients with ventricular tachycardia or suspected cardiomyopathy. I hope you enjoyed this presentation, and I would like to invite you joining me here in my future video presentations. Thank you.